I'd like to welcome you to CHIRPS, the clinical hair instruction, reasoning, and problem-solving program for hair loss practitioners around the world. The CHIRPS program is part of the Donovan Hair Academy and offers hair loss practitioners with the opportunity to fine-tune and develop their skills in clinical reasoning and problem-solving. These CHIRPS modules are part of the many training programs we offer here at the Donovan Hair Academy. The CHIRPS modules are free, and they're free for practitioners around the world. They're geared to practitioners with some prior knowledge and experience in diagnosing and treating hair loss. If you're brand new to the diagnosis and treatment of hair loss, you may want to contact us for some introductory programs we offer in this area. The CHIRPS modules do assume that you have some prior knowledge and background. The Donovan Hair Academy seeks to educate practitioners in the diagnosis and treatment of hair loss. The CHIRPS program is one of these programs at the Donovan Hair Academy. The Evidence-Based Hair Podcast is another such program. Each week I review some of the latest research in the field of hair loss, and I discuss with listeners how exactly this research ties in with things that we've come to learn in the past. And as part of the Evidence-Based Hair Podcast each week, I discuss key diagnostic pearls and treatment tips. The Evidence-Based Hair Podcast is available on YouTube or wherever you enjoy listening to your favorite podcasts. To learn more about the Donovan Hair Academy and the CHIRPS program, you can email us. My team is available at info@donovanhairacademy.com. So what's the basis of the CHIRPS program? Well, it's really quite simple. Patients around the world send us some challenging cases each week. They may be challenging questions about diagnosis or challenging questions about treatment. I then answer the patient's question and return the answer to the patient. I record my answers and all the detailed discussion in a module which becomes part of the CHIRPS program. Each module has objectives, teaching points, and ends with a series of multiple choice questions that ensures that our listeners have met the objectives of the module. If you're a patient and you'd like your question answered, you can submit it through our online portal, and that is donovanmedical.com/CHIRPS. We don't accept emailed questions because we need patients to submit their questions in a very formal way and give us consent and permission to publish various aspects of their question, their photos, and their story. And all questions and photos and details that we present here have been granted permission from the patients. So let's begin module number 1. I'd like to review with you in this module the causes of telogen effluvium. I'd like us to consider the importance of low ferritin levels in postmenopausal women. I'd like to review the 4 categories of conditions that give low ferritin. I'd like to review the differential diagnosis of a red scalp, and I'd like to review the differential diagnosis of chronic shedding. So let's begin. Here's a wonderful question that was sent in, and I thank the individual for submitting this question. The question reads, I am in my mid-50s, healthy and fit, not taking any medications except hormone replacement therapy, which started last year. 2 years ago, I had a dramatic increase in hair shedding, more than 300 hairs a day. My temple area was always a bit thinner, and so that area had shown the most visible hair loss, but overall, the hair loss is diffuse, top, sides, and back. The hairs that fall are almost all long hairs with a white bulb attached. I had started experiencing my first menopausal symptoms a few months prior to this increase in shedding. The excess of shedding lasted 6 months or so and then slowed down, and things seemed to return back close to normal, and the hair density improved. It was during the time of normalization that I started hormone replacement therapy. After about 5 months on HRT, hormone replacement therapy, I cut my hormone dose in half. Less than 2 months later, the massive shedding started again. Other considerations may be that 4 months prior to this second shedding, I was sick with a fever, not COVID, and I also had the COVID vaccine around that time, which triggered another fever, which lasted for a couple of days. I have had blood tests done and everything is within a normal range, except my ferritin is 15. Vitamin D and thyroid is normal. My scalp is itchy at times, but not constant, and not sore or red or sensitive. There's a visible difference in how thick my hair looks now. It feels like I've lost 50% of my hair. I should note that I'm always under chronic stress, which has increased significantly since menopausal symptoms began 2 years ago. Could this be AGA, TE, androgenetic hair loss, telogen effluvium, or both? And depending on the diagnosis, could minoxidil work? Or finasteride? Or something else? And so again, I thank this individual for submitting this question. I hope that the answers and discussion that we present today will ultimately be helpful for this individual who has kindly sent in this question to our program. So the individual sends in these photos. This is a photo of the top of the scalp with different views, with different lighting. And we can see here some very slight widening of the central part. Another photo of the central part, or the part down the middle. The central part is very relevant when we examine the scalp and we look at the scalp. A central part that is widened just tells us there's hair loss, but a central part that is widened with a pretty normal part at the back of the scalp suggests perhaps there's androgenetic hair loss here. A central part that is widened and a back part behind the ears that is widened as well really tells us there's diffuse loss and is more suggestive of telogen effluvium. Patient sends in photos of the temples, and we can see some temple loss here with what appears to be some regrowth happening in the temples at the time this photo was taken. We will come back to this concept in a minute, but temples are challenging to interpret. Temple hair loss that's very significant can occur in telogen effluvium, but temple changes can occur in androgenetic hair loss as well. So we have to be careful about overinterpreting temple loss, but certainly very significant temple hair loss is common in telogen effluvium. This is a front view of the scalp where we often look to see if there's frontal hairline changes that are common in scarring alopecia, like frontal fibrosing alopecia. And we, in this view, come to see that there is hair loss, and we wonder here if there is a triangular pattern of hair loss, which would be in keeping with what's known as the Olsen pattern of female pattern hair loss. If there's more hair loss here than back here, that would suggest it's not perfectly diffuse loss, and that would be more favoring some degree of androgenetic hair loss that is present. And here's a picture of the back of the scalp. Very helpful to have a parting of the back of the scalp where we can appreciate that there is some widened part at the back, which would be suggestive of diffuse loss. Diffuse loss can occur in telogen effluvium. Some women with androgenetic hair loss have diffuse loss as well, but usually in the early stages of androgenetic hair loss, the hair loss is more favoring the front and top of the scalp. The scalp appears to be a bit red as well. And so these are the photos that have been sent in by the patient. We have what appears to be diffuse loss. There's nothing in particular here with these photos that suggest anything particularly concerning at first glance, like a scarring alopecia with patches of hair loss. There's no circular areas of hair loss that favor alopecia areata. But certainly the overall impression that one has at first glance is that this is probably a non-scarring alopecia. Androgenetic hair loss and telogen effluvium being the more common types of non-scarring hair loss. But how do we diagnose hair loss? Well, the diagnostic set, or SET, that I use to think about hair loss refers to the story, the examination, and the tests. We diagnose hair loss with this set: the story, the examination, and the tests. And those tests could be blood tests, biopsies, hair collections, fungal scrapings, hair trichograms. We need the story and we need the examination. These are the most important features, and the examination includes trichoscopy, as well as a clinical examination, looking from above, looking from the sides, pulling the hair to the sides, looking at the central part, looking at the temples, looking at the part at the back, looking if the scalp is red, looking if the scalp is scaly. So we really do need the story. And I think that often we don't appreciate just how important the story is. Every single thing in the patient's life matters. A patient that moved homes 2 months ago matters. If the hair loss happened 2 months ago or 1 month ago. A patient that's been under chronic stress matters. A patient that started a new medication, that matters. All aspects of the story matter. And certainly the examination matters, and the trichoscopic features matter. We can often get to the diagnosis with a good story and a good examination. The tests help confirm that, but the tests themselves usually aren't what we really should be relying on to get to the diagnosis. And so if you're thinking, what does my patient have? I'm going to order some blood tests to figure it out. That's an indication that you don't understand truly the diagnosis. The diagnosis will never be in the blood tests. The diagnosis lies in the story and the examination. You might say to me, I think my patient has telogen effluvium. The diagnosis lies in the blood tests for the low iron or the thyroid problem. No. The diagnosis lies in the story of the excessive shedding and the examination showing diffuse hair loss and positive pull test perhaps. If you think there's a telogen effluvium, the blood tests will give you an indication of what might be the cause of the telogen effluvium, but the diagnosis doesn't lie in the blood tests. And so the story and the examinations are really, really critical. And so in this particular case, I don't have the full story, and I don't have the opportunity to examine the scalp with trichoscopy. And so what I'm able to do is offer some suggestions on what may be the possible diagnosis and what the considerations are needed. And of course, we can use this test to hone and develop our skills in thinking about hair loss. So let's take a look at the question again. History is very, very important. And the one thing that I would really like listeners to think about is just how important the history is. When I was training in dermatology, many dermatologists really love dermatology because it's a visual specialty. And you just look at the scalp or look at the skin or look at the nails or look in the mouth and voila, you have the diagnosis. Well, hair loss is a little different. Hair loss is very much of a auditory specialty. The story really matters. And so if you think you can walk into an examination room and say, nice to meet you, let me look at your scalp and I'll give you the diagnosis, you don't fully appreciate the importance of the story. The story really does matter when it comes to hair loss. And so many of the misdiagnoses come from a failure to pick up some simple points on history. And so I would like to emphasize that the history really is important. So this patient says, I'm in my mid-50s, healthy and fit, not taking any medications. So that's really helpful. We have a fairly healthy patient, 50 years of age. She's on hormone replacement therapy, started last year. 2 years ago, she had dramatic increase in hair shedding, more than 300 hairs per day. That's pretty high. Normal hair shedding is 50 hairs, 60 hairs, 80 hairs. If you ask patients, what's your normal shedding? Most people without hair loss really won't know. But the reality is most people without hair issues have shedding of 35, 50, 60, 22, 30, 34 hairs per day. We say 100, but the reality is that most patients with out hair loss don't have 100 hairs per day. So we use 100 as a cutoff, but that's generally quite excessive for most people. If you wash your hair every second day, then sure, you can expect 150 hairs to come out in the shower. If you wash your hair every 3 days, then all that accumulates, and then when you shampoo it out, sure, maybe you'll have 200 hairs come out, or 250, that would be normal. If you wash your hair once a month, you could have 1,000 hairs, you could have more come out, that would be normal. So we expect 50, 60, 70 hairs per day maximum to come out without hair loss, but generally it's between 22 and 40. So this patient tells us she has 300 hairs per day. That's excessive shedding. It's a little bit higher than the shedding we see in androgenetic hair loss. It's a little bit higher than the shedding we see in seborrheic dermatitis. So it suggests that there's an acute shedding phenomenon going on. The patient says, my temple area was always a bit thinner, and so that area has shown the most visible loss, but the hair loss is all over. This is a really perceptive comment by the patient. Many women have hair thinning in the temples normally. And so that's really important to keep in mind. The normal female hairline has this contour to it where thinning in the temples is quite normal in some cases. And when you lose hair, if you take 10% of hair from the temple, 10% from the side, 10% from the back, 10% from this side, guess what shows the most changes? The temples and the sides here, the parietal scalp. And so it's very common with hair loss for patients to focus a lot on the temples because that area was thinner to begin with. And that's why telogen effluvium often has more marked changes in the temples. So we're developing a story here of acute hair loss, 300 hairs per day. The patient says the hairs that fall are almost all long hairs with a white bulb attached. So here's a patient that I'm learning a lot about, that it's an individual that has some pretty detailed understanding about hair cycles. Either this individual has read quite a bit herself, has been to physicians, trichologists, and has come to learn quite a bit of hair. She is telling us they're long hairs, they're not short hairs. So she's telling us quite a bit of information. This is the typical telogen hairs that we would expect. She's not seeing a lot of short hairs, which are more typical of androgenetic hair loss. So I'm learning a lot about the patient by her story. I'm learning that she's very, very knowledgeable about hair to begin with. I started experiencing my first menopausal symptoms a few months prior to this increase in shedding. The excess of shedding lasted 6 months or so, then it slowed down and things seemed to return back close to normal shedding, and the hair density improved. So we had this acute shedding episode, and then the shedding stopped. And it returned to normal shedding. That's really, really important. Something shut off. The hair density improved. The patient has not told us whether her hair density came back to normal. The shedding came back close to normal, but we're not told that the hair density came back to normal. It was during this time of normalization that I started hormone replacement therapy. About 5 months on hormone replacement therapy, I cut my hormone dose in half. 2 months later, I had massive shedding again. So the patient is pointing out that it was massive shedding. And so this subtle change in hormone therapy dose triggered a massive shed. Other considerations may be that 4 months prior to the second shedding, I was sick with fever. I also had a COVID vaccine, and that triggered a fever which lasted a few days. So these are all potential triggers for shedding. As we think about shedding, we have to think in our mind, why is a patient shedding? And so we have to be comfortable thinking about the causes of shedding, which we'll review in a moment. But as a hair practitioner, it's important to have this list at ease. And I think of the SEND memory tool for the causes of shedding, the things that send a hair from the growing phase to the shedding phase, and that's stress, scalp disease, endocrine issues, nutritional issues, drugs, and diseases in the body. And so when I have a patient who's saying, I'm shedding, I'm shedding, I'm shedding, I'm thinking to myself, was there stress? Is there some kind of scalp disease like seborrheic dermatitis, psoriasis, dermatomyositis, lupus? Is there something going on the scalp that triggers shedding? Is there an endocrine issue like hyperthyroidism, hypothyroidism, Cushing's syndrome, adrenal insufficiency, hyperparathyroidism, pseudo-hyperparathyroidism? Any endocrine issue you can think of can trigger shedding. Hypogonadism, pituitary stalk issues, they all trigger shedding. Every single endocrine issue. Of course, the famous ones are the thyroid issues. So SEN is nutritional issues. Was this patient on a diet? Has she become malnourished? Is there a reason for her to be malnourished? Does she have deficiencies of certain vitamins or minerals like low iron? And D is drugs, medications. Has she started a medication? Has she stopped a medication? Aha, she has stopped the HRT, or at least reduced it by half. And then D is diseases in the body. Does she have some kind of systemic disease that's triggering shedding? So with anyone with shedding, I'm thinking about SEND, and we're trying to get a sense of this. And of course, we're trying to think if there's a mimicry of shedding going on, and we'll come back to this. So the patient is telling us that she shed after reducing the hormone replacement therapy. She had fever, she had a COVID vaccine, and these are all triggers of shedding. Fever would fit under the D category for systemic disease. Patient says, I had blood tests done, everything was fine, except my ferritin was 15. Vitamin D and thyroid is normal. So 15 ferritin is pretty low. And we'll come back to this in a minute, but that is low, and that would fit under the N of nutritional issues. So does she have a reason for shedding so far? Yes. She has stress. She has nutritional N, the low iron. She has D, drug. She has a reduction in the dose of the HRT. She has systemic disease, fever from an illness, and COVID vaccine-induced fever. And the COVID vaccine would also be under drug or medication or treatment. So she has a lot of reasons to have shedding. She says the scalp's itchy at times, but not constant, not sore, not red, not sensitive. Very well educated patient about hair loss. The way this question is coming in, and this is the question that comes in, is showing me that she's thought a lot about her hair loss. She's telling us it's not constant, it is itchy, it's not red, it's not sensitive, it's not sore. And so it's itchy. There's many, many causes of an itchy scalp. Telogen effluvium gives itching. Stress gives itching. Seborrheic dermatitis gives itching. But the fact that she says it's not red, not sensitive, not constant, really helps us because it suggests it's probably not a more serious cause of an itchy scalp, like a scarring alopecia. It still could be, but it's much less likely. The scalp is itchy, and it is a bit red in the photographs, at least from what I can see, subtly. And so, could it be seborrheic dermatitis? Could it be psoriasis? Certainly possible. There's a visible difference in how the hair looks. So the patient's telling us, I have this shedding going on, but there's less hair on my scalp. And she says it feels like I've lost 50% of my hair. And so 50% of the hair over a 2-year or a 3-year period, that's certainly very significant, and that's very troublesome. And so we can appreciate that that would be quite difficult for many patients to experience that type of hair loss. And so she's asking us, is this androgenetic hair loss? Is this telogen effluvium, or both? And depending on what it is, how do I treat it? So let's take a look at this. The thing that I would like to introduce you to in Module 1 is the importance of the hair loss timeline. The hair loss timeline is extremely valuable, and I see the hair loss timeline as similar to an ECG tracing for the heart. And the hair loss timeline is a tracing of shedding and of events. And so when a patient tells me they have hair loss, I draw on a piece of paper a calendar, taking us back to when the hair loss started. And if it goes back 10 years, maybe I'll go back 10 years. If it goes back 1 year, I'll go back 1 year. She's taking us roughly back 2 years in this case. So I draw 2022, 2021, 2020. I draw lines for the beginning of the years. And she tells us that in early 2020, give or take, she had menopausal symptoms. She had shedding that started in early 2020. She started HRT after that. She halved her dose after that. She had some fever that happened during this time as well. And her shedding happened in 2020, sometime after her menopausal symptoms started. Then the shedding went down. When she reduced her HRT, shedding went up again. She also had the COVID vaccine and fever type illness just before the second shedding episode as well. And so the black line represents the shedding pattern. Shedding went up, shedding went down, and shedding went down pretty much to normal. And that's really, really important because that tells us that shedding shut off. And that's very valuable because it tells us that there truly was a trigger and the trigger resolved. And then there was another shedding episode, and we don't have a lot of information about what happened to shedding in this particular submission. So that would be certainly important. Did the shedding shut off now, or is it still elevated? And we know there's been about 50% loss of density. What we don't know is after the shedding shut off, there was an improvement, but how much did the hair come back? These are certainly questions we'd want to ask the patient. So this is a hair loss timeline, and I really view it as very similar to an EKG. I think of this tracing of the shedding and its importance. In acute telogen effluvium, shedding goes up. You fix the trigger, shedding goes down. In androgenetic hair loss, shedding goes up and it fluctuates. But until treatment is started, there's often shedding above baseline. Really important to remember that shedding can occur in androgenetic hair loss, especially early on. In chronic telogen effluvium, which is a hair shedding condition in women 35 to 70, where they develop shedding for no good reason, women have massive shedding, the shedding reduces, sometimes even shuts off, and then there's shedding again for no good reason, and it can be quite significant. Could this be chronic telogen effluvium? Could be, but there's really more evidence of acute telogen effluvium going on here, trigger-induced telogen effluvium. When you're thinking about triggers, I think there's a trigger. You're probably not dealing with chronic telogen effluvium as much. Scarring alopecia can cause shedding as well. Shedding goes up, and then shedding fluctuates from time to time. Shedding might increase with stress. Shedding might increase at different episodes where the scarring alopecia becomes active. And of course, with treatment, we hope the shedding goes back to normal. But scarring alopecia can give shedding. It can give a little bit of shedding or a lot of shedding, so it is quite variable. Seborrheic dermatitis can give shedding. Usually it gives very minor shedding. But if there's significant seborrheic dermatitis that builds up, and psoriasis is the same. If there's a lot of inflammation in the scalp, you get shedding that increases. And then when patients wash their scalp more, shedding goes down. Or if they use anti-dandruff shampoos, the shedding goes down and hopefully shuts off. When the winter comes and heating goes on and stress becomes high, shedding can go up because seborrheic dermatitis flares. And so these are the tracings of shedding that I think about every single day of my practice. And it's very, very valuable to me because it gives me tremendous clues to what's going on for the diagnosis. So our patient has this type of a tracing, and this is her hair loss timeline. And so I'm immediately beginning to see with her information that there seems to be some kind of a shedding trigger. What is the cause? Well, we have low iron, we have medications, we have this illness, we have having the dose of the HRT, so we have a number of triggers that are present. It's interesting that her shedding shut off completely when her ferritin was still 15. And so we have to be pretty careful about attributing that ferritin of 15 to her entire story. It's very tempting when blood tests come back to say, you have a ferritin of 15. That's the cause of your shedding. We just need to fix your ferritin and everything will be just fine. That's very commonly done in the hair loss world. And that is inaccurate. That is dangerous diagnostically and treatment-wise. Because some people have low ferritins and it causes shedding, but some people have low ferritins and it doesn't cause shedding. So we need to keep that in mind, and we'll come back to that. But this patient has taught us, listen, my shedding shut off completely. Hair came back, then it increased again. We have to respect the fact that maybe the ferritin is really relevant, and maybe it goes from 15 to 10 to 21. She eats more red meat, or she eats more iron-rich foods, or she takes a supplement and then it goes up and then it goes down and then it goes up. So we do need to keep that in mind. But here's her tracing. And her tracing is certainly suggestive of a telogen effluvium. So if this is new for you, wonderful. I hope the hair loss timeline really is valuable. So what are the most likely diagnoses here? Well, there's clearly a telogen effluvium. The trigger, hard to say, we need more information, but low iron, COVID, she didn't have COVID, but fever, COVID vaccine, stress, reducing the HRT dose, these are all the potential triggers. Androgenetic hair loss, I think, is likely. We can't say for sure. Certainly a trichoscopic exam will be very valuable. Seeing the scalp up close to see miniaturized hairs to really prove to ourselves that there's a variation in the caliber of hairs, or anisotrichosis, where we have thinner hairs in the front, thicker hairs in the back. When there's a variation in the caliber of hairs in more than 10% of hairs in the front, sometimes we give it a cutoff of 20 just for ease of discussion. But when there's a significant amount of miniaturization happening, we have to think about androgenetic hair loss. A biopsy can confirm androgenetic hair loss if we're not sure, if we're not confident in trichoscopy or the clinical exam. A 5-day hair collection can also confirm whether there's any component of androgenetic hair loss, where you get a patient to avoid washing their hair for 5 days. Then you get them to shampoo their hair over a wash basin, and you collect all the hairs on a gauze that get shampooed out. If there's a lot of thin, small hairs, less than 3 centimeters, and there are specific cutoffs, this may be suggestive of androgenetic hair loss. So there's ways of really getting to whether this is androgenetic hair loss. We don't have to guess, but certainly trichoscopy will be very valuable. But if you're convinced that the hair part here is thinner than the hair part in the back, then that's suggestive of androgenetic hair loss. And certainly here I wonder about seborrheic dermatitis. I do think there's a bit of redness in the scalp. There is some itching. It's hard to say for sure. Clearly trichoscopy will be valuable where we see yellow scale. There are some dilated type blood vessels that can be seen in seborrheic dermatitis, but the yellow scale is very valuable with redness in the scalp. And so these are the potential diagnoses that we're dealing with here, but telogen effluvium is very, very likely to be a main issue here. So what do we need to rule out? Well, we need to rule out some of the redness that seems to be here in these photos. It's very subtle. The redness may be seborrheic dermatitis, but there's other causes of redness we need to think about. They don't seem to be present, but it's important that you develop a differential diagnosis for scalp redness, including scarring alopecia, psoriasis, allergic contact dermatitis, irritant contact dermatitis, dermatomyositis, scalp rosacea. Seborrheic dermatitis is the more likely one, and statistically speaking, this is common. 10% of the world, 20% in some groups have seborrheic dermatitis. So it's very common. 50% of the world has dandruff at some point in their life, and seborrheic dermatitis is a close cousin. Psoriasis affects 5% of the world. Allergic contact dermatitis, irritant contact dermatitis is way more common than we realize. Shampoos, hairsprays, mousse, gels, hair dyes, these can all contribute to contact dermatitis. And so we always have to be thinking about contact dermatitis. Does the fragrance in a shampoo contribute to redness in the scalp and shedding? Does the preservatives in the shampoo contribute to an allergic contact dermatitis? If the patient has redness and rashes on the neck or on the ears or on the face or on the back of the scalp, the chances of contact dermatitis go up. Redness of the scalp alone, without anything wrong with the face or the chest or the ears or the neck, means allergic contact dermatitis is lower on the list of chances. And some of these issues like dermatomyositis, which is an autoimmune condition, rosacea, scarring alopecia, these are much less common in a scenario like this, but we need to be thinking of them. And so when I approach patients with hair loss, I really am very much thinking about ruling out conditions. As I say to clinicians that I work with, I walk into the room with a piece of paper. It's an imaginary piece of paper, although I do walk into the room with a piece of paper. But I walk into the room with an imaginary piece of paper, and it has 25 diagnoses on it. And my job is to cross those out as I examine the scalp, cross them out as I listen to the story. I can do that quickly within a matter of a few seconds, but diagnosing hair loss is very much about ruling out conditions. So I don't walk into the room thinking, let's go see what this patient has. It's very much, let's go see what this patient doesn't have. Of course, I need to be confident with the final diagnosis that that's indeed what they have. But I want to quickly rule out scarring alopecia, exit off the list. Dermatomyositis, cross it off the list. Tinea capitis, cross it off the list. Trichotillomania, cross it off the list. Alopecia areata, cross it off the list. It's very, very important that we learn to develop those skills of ruling out conditions. So what are the causes of shedding? Well, it's really important as you develop your skills that you don't equate shedding with telogen effluvium. There are many conditions that give shedding, and in fact, most hair loss conditions give shedding. Some conditions give minimal shedding that you can only pick up sometimes subtly on a biopsy when you look at the percentage of telogen hairs. But a lot of conditions give shedding, so please don't equate shedding with telogen effluvium. Hey doc, I have shedding. You have telogen effluvium. That's incorrect. So shedding can happen with acute telogen effluvium, like the causes that we've discussed. So we have to think here about shedding from some causes that we've missed. The patient tells us her ferritin was low, her vitamin D was okay, her thyroid was okay, but maybe her zinc is low. Maybe there's some other autoimmune issue here. Maybe there's some other endocrine issue. Maybe there's some other cause of telogen effluvium. So maybe there's another cause we've missed of acute telogen effluvium. Maybe she has chronic telogen effluvium. Maybe all this is a red herring, and she's shedding and then going back to normal, and shedding and going back to normal. And this information about the low iron, the COVID vaccine, the illness, it's just a red herring. She was going to shed anyways. That's unlikely here, but chronic telogen effluvium is a condition that comes and goes for no reason, and sometimes these kind of triggers encourage the shedding to happen. Maybe she has a very subtle scarring alopecia that's just about to develop. It's in the early stages, and she gets the shedding. And then it goes quiet. And then 2 months later, 4 months later, it comes more active again. Trichoscopy and a good scalp exam will, of course, evaluate whether there's any possibility of scarring alopecia. I'm not really suspicious of that because shedding really returned back to normal, and the pictures don't suggest that there's a scarring alopecia. Alopecia areata can cause shedding. There's acute alopecia areata where you get circles of hair loss, but there's this diffuse form. There's an incognito form which gives shedding. We always have to have it in mind. Seborrheic dermatitis can give shedding. Any scalp inflammatory disease can give shedding. And so when a patient says, I'm shedding, I have this list in my mind. Are you shedding from acute telogen effluvium, chronic telogen effluvium, scarring alopecia, alopecia areata, seborrheic dermatitis, psoriasis, dermatomyositis? I don't think to myself, you have telogen effluvium. Thanks for letting me know. So it's really important that we keep that in mind. The story does fit well with telogen effluvium in this case, and probably 2 episodes of telogen effluvium. They could be different triggers. The trigger in 2020 may be different than the trigger in 2021, which may be reducing the HRT dose, which may be the vaccine, which may be the illness that she had. And so we need to perhaps go back to the history and speak to this patient in greater detail about some of these triggers and make sure that we really understand which triggers could be involved. If there's a trigger that comes and goes, then we can be satisfied to know that the trigger's gone and hopefully the hair density will come back. Telogen effluvium often happens 1 to 3 months after a trigger. And then when the trigger's gone, the shedding improves. And so if the patient has fever, we can get shedding 1 to 3 months after the fever. Once the fever goes away, we expect shedding to improve and density to come back. The thing we're uncertain of in this story is the patient has 50% loss. 2 years of shedding, 50% loss. She has this hair loss which is starting around menopause. And so the question we have to ask here is there a possibility that there's some component of androgenetic hair loss that's introducing itself onto the scene? Androgenetic hair loss can develop in 8-year-olds, 10-year-olds, 20-year-olds, 30-year-olds, and 40-year-olds. It often develops in the 20s, 30s, and 40s, but in some women it develops in the 40s. And in fact, maybe 20% of women by the age of 30 will have some androgenetic hair loss. But by the time of 55 and 60, it may affect 40% or 50% of women. So there is a significant increase in the prevalence of androgenetic hair loss perimenopause and after. And so we certainly need to be aware of the possibility that this may be androgenetic hair loss that's developing. And one of the key things for this patient is really to get to the bottom of, is this androgenetic hair loss as well? It's okay to have 1 diagnosis. It's okay to have 2, 3, 4, 5. We're not limited. And so it's very important in a situation like this not to go into the room thinking, I've got to figure out this patient's diagnosis. You go into the room thinking, I have to figure out the patient's diagnoses. Remember, you go into the room with 25 conditions on your list, and your job is to cross them out. And if you can't cross any out, well, then the patient has 25 diagnoses. Of course, most patients have 1, 2, or 3 diagnoses, or 4. But I'm concerned here that there may be some androgenetic hair loss here. There's hair shedding developing postmenopausally. We're not getting a complete return of density. Of course, I need more information. There seems to be a bit more thinning in the front, perhaps, than other areas. So I am concerned about androgenetic hair loss. I'm also concerned about the low ferritin. It's really important to understand that ferritin can often be low in women. but it's not commonly low in postmenopausal women. And that's really important to understand from this module. Most women 55 to 60 have ferritins about 70, 75. Some have 50, some have 150. Most women don't have a ferritin of 15, so that's abnormally low. So if we look at ferritin levels from 50, 60, 70, see it increases. It increases over time. And most women at 50 have ferritins 55, 60, and it goes up. This patient has a ferritin of 15. That's abnormally low. And so it's really important to be concerned because we need to figure out why ferritin is low. And the thing that I would encourage you to pay attention to in this module is whenever you have low ferritin, under 40, you need to have an answer for why it might be low. It may be that they're not taking in enough iron-rich foods. It may be that they have a predisposition to absorb iron poorly. It may be that the periods are heavy in a premenopausal woman. It may be that they have other issues as well, but you need to come up with an answer as terms of why the ferritin might be low. And if you're not sure, you need to get your colleagues involved, the general practitioner, an internist, a gastroenterologist, a gynecologist. You need people on board to help you figure out why is the iron low, but you need an answer. That's really important. And so how likely is it that low ferritins cause hair loss? Well, in the hair loss world, we often have a very simple rule, and that is if the ferritin is low, it's causing hair loss. That's wrong. It permeates our field, but it's wrong. As you go down the ferritin values from 70 to 40 to 20 to 16 to 10 to 5, it becomes more and more likely that a low ferritin is causing hair loss. So if a patient has a ferritin above 70, it's probably not contributing to hair loss. But if a patient has a ferritin of 40, it's probably not relevant to their hair loss. The iron is probably just fine for their hair. But a ferritin less than 10 is very likely relevant. Still not 100%. There are some patients with ferritins of 10 that are walking around that don't have any hair loss. And so it's not universal. So is giving iron likely to help a person's hair? Well, if you have a patient with a ferritin of 10, it's pretty likely that giving iron is going to help. But it's not 100%. So it's really important not to promise patients. I see you have a ferritin of 10. I'm looking at your blood test right here. You have a ferritin of 10. Take the iron supplement I give you. Your hair will be fine in 5 months. You have to be careful. A ferritin of 10 is very low, and I'm certainly concerned, and it's very likely that giving iron will help, but it's not 100%. A ferritin of 10 to 15, it's quite likely that iron will help. It's only a small chance it won't help. But as you go up, there's a good chance it'll help, but a good chance it won't help. And then as you go higher and higher, there's a good chance that giving iron will do nothing. And where we get into trouble and where we make mistakes is we have patients with a ferritin of 26, 28, 31, and we say to our patients, oh, it's less than 40. I've learned that if there's a ferritin of less than 40, it's really bad for the hair and it's the cause of hair loss. I see your ferritin is 31. It's very low and you need to take iron. Often the iron does nothing. And often patients take iron, which they should. We need to take iron if it's less than 40, but we need to be aware that it may not be relevant at all. And we're doing a bit of guesswork. And that's okay. We really do want ferritin levels to be above 40, and some would say 50 or 60, but we have to be careful promising patients that if they take iron, their hair issues will be better. So this patient has a ferritin of 15, and it's really important that we advise this patient to discuss this with her practitioners. We may want to pull up old blood tests. If the patient has had ferritin of 15 for the last 40 years, I'm less worried because clearly she didn't have hair loss when she had a ferritin of 15 20 years ago. But nevertheless, we do need to take this seriously, especially if it's a new onset iron deficiency. So we want some other tests, and perhaps this patient has had them done, but we want a full CBC panel, complete blood count. We want to know the RDW, the red cell distribution width. The RDW goes above 14 when there's significant iron deficiency. It goes above 17, 18, 19 when there's real significant iron deficiency. The hemoglobin, as part of the CBC, goes below 12 when there's an anemia or 120 units in international units. The MCV starts going below 85 when there's iron deficiency developing. 78, 70, 60. As you get lower and lower, of course, we want to be thinking about thalassemias and other issues that affect red blood cells. The mean corpuscular hemoglobin concentration and the mean corpuscular hemoglobin also change, and the MCH goes below 28, 27 when there's significant iron deficiency issues. So we really want to look at all the values. We want to know if there's iron deficiency anemia or just an iron deficiency. The patient here is telling us that there is just a ferritin of 15 as the only abnormality. But we really want to know other tests in this situation. We want to know B12 levels. Unless the B12 is normal, it's difficult to know if a ferritin becomes normal. And so if this patient's ferritin goes up and the B12 levels are abnormally low, it is difficult to interpret ferritin. So we can only really interpret ferritin when the B12 levels are normal. We want to know about folate levels. We might want to consider inflammatory markers if the history dictates. When we're thinking iron deficiency, we want to think about other minerals that are often deficient with iron, and that's zinc. And there's a bunch of other tests which we might consider, but it depends on the history. And so that's really, really important here. When a patient has iron deficiency, we really want to ask some good questions to figure out what other blood tests are relevant and if these blood tests are relevant to the patient shedding. So again, the story is very important in shedding issues. So if the patient has joint symptoms, my joints ache, my fingers ache, when I wake up in the morning, my hands are stiff for an hour, we might want to order a rheumatoid factor or an anti-CCP looking at rheumatoid arthritis. Might want to look at some inflammatory markers. There's nothing in this history that suggests the patient has joint symptoms. So unless there is, I wouldn't necessarily order this. If there's muscle symptoms, certain skin rashes, I might order a creatine kinase to look at muscle symptoms. An autoimmune panel with an ANA. Again, if there's nothing to suggest it, I don't just order these tests. If the patient has high blood pressure that's newly developed, I might order a creatinine to look at kidney function. I might order a urinalysis. I might order cholesterol. So I really want to think carefully about the story of this patient. If the patient has dry mouth and dry eyes, I might be thinking about other autoimmune diseases like Sjogren's syndrome, and I might order an ENA or an extractable nuclear antigen. Nothing here suggests that, so I wouldn't just order these just to order them. The patient has low iron, so there is some nutritional issues here. So I might think about ordering a zinc, as I mentioned before, a folate. A B12 may be relevant because interpretation of iron can only be done when B12 levels are normal. Especially interpretation of saying that someone's ferritin is finally normal. If there's hair growth on the face, voice changes, acne, muscle changes, mood changes, we might want to order a testosterone and a DHEAS. That's really important when someone has new onset shedding, new onset androgenetic hair loss. But I might not order a testosterone and a DHEAS just to order it, but if there's reason to order it, I might. If the patient has diarrhea and episodes of diarrhea, I might want to order a ferritin with the zinc, as I mentioned. These are absorbed from the gastrointestinal tract. Might want to order a CBC to look for an anemia and a TSH in the event that hyperthyroidism is the cause of the diarrhea. Might want to order a celiac screen if there's iron deficiency anemia that's here. Often a celiac disease will be diagnosed in patients prior to 55 and new onset hair shedding, but it may not be. And so in iron deficiency anemia, we want to be thinking about celiac disease as well. If there's muscle weakness, bruising, fat redistribution, buffalo hump, so thickness at the back of the scalp, at the back of the neck, striae, we want to be ordering an AM cortisol. We always want to be thinking about sexual history, and we don't always ask patients in detail, but it's really important. Is there a possibility this patient has a sexually transmitted disease? Syphilis screening may be relevant. HIV may be important. Unless we think about it, unless we're comfortable asking, we will miss it. If there's shortness of breath, cough, we might want to order a chest x-ray and ECG. We want to always ask about travel history. Did the patient come back from various parts of the world? Did they take certain drugs while they were away? Malaria prophylaxis, antidiarrheal type medications. Were they ill while they were away? Did they just come back from a trip to parts of the world where dengue is common? Dengue is a wonderful cause of shedding. So travel history may be important. And if there's abdominal pain, we might want to order liver enzymes and abdominal ultrasound and other imaging perhaps as well. So I can't emphasize enough with patients with chronic shedding just how important it is to get a sense from head to toe quickly, doesn't take long, of any systemic issues that are present. So I may ask the patient, I'm about to ask you some questions. They're just standard questions that we ask as part of routine health, but I'd just like you to answer yes or no. Any headaches? Any vision changes, any sore throat, any trouble swallowing, any diarrhea, any cough, any chest pain, any rashes, any joint pains, any swelling in the feet. And so within a matter of a few seconds, I can get a sense whether any of these issues might be relevant. Any dry eyes, dry mouth. And so we don't necessarily do these examinations and tests by ourselves. If you're comfortable with it and you have the skills to, then certainly you have the skills to do that. If you're comfortable evaluating for Sjogren's, great. If you're comfortable from your past training looking at joints, great. If a patient says they have sore joints in the morning. But if you're not, you want to get your colleagues involved, either the general practitioner or another colleague, a rheumatologist, a gastroenterologist, an endocrinologist. But remember, you're not in this alone. It's a team effort. But anyone with chronic shedding, we need a history and examination in detail. Chronic shedding doesn't mean telogen effluvium necessarily, and that's really a key part of this module, is that when you hear shedding, I'd like you to have a broad differential on your list. So why do people have low iron? Well, one of the objectives of this module is to remember that there's 4 causes of low iron: poor intake, poor absorption, excessive loss, and excessive demand. So let's take a look at these. Because as we're speaking to this patient that says, oh, by the way, I have a ferritin of 15, our question to the patient is, why do you have a ferritin of 15? Is it because of poor intake? Is it because of poor absorption? Is it because of excessive loss? Is it because of excessive demand? And if you can't figure it out, you have colleagues that can help you. So you're not in this alone. Poor intake can come from poor diets, not enough food or malnutrition, patients with what is often called in the older literature as tea and toast diets, patients who just aren't consuming very much highly nutritious foods. May have reason to have low iron. What about poor absorption? Well, to absorb iron, we need the stomach to be nice and acidic. And so if you block that acid with antacids, you increase your risk of iron deficiency. The stomach acid can be affected by gastric surgery, bariatric surgery, can affect a whole bunch of micronutrients, iron, zinc, selenium, lots of different things. Vitamin C deficiency can occur with some states of malnutrition, and vitamin C is important for iron absorption. Celiac disease, excessive coffee and tea can block iron absorption, and so can heavy metal intoxication, and that's much less common, of course, but we need to think about it in certain parts of the world. Excessive loss is very important to think about and can be very concerning. In premenopausal women, it's common to have excessive loss from heavy periods, so we need to be thinking about that. But there can be heavy loss from other bleeding in the gastrointestinal tract, gastric ulcer, a duodenal ulcer, bleeding in the lower GI tract, hemorrhoids, but there can be bleeding inside the body as well. Fibroids can give bleeding. And then excessive demand. The body is using up the iron. The body wants iron for other reasons. So iron deficiency can occur when you are growing. Children and adolescents can have iron deficiency because they're growing. Pregnancy is a very important cause of iron deficiency. The mom needs iron, baby needs iron, so it's very common to have iron deficiency. Lactation is another common cause, and cancer is another cause that we have to be aware of. So why does this patient have low iron? I don't know, but it needs to be determined. So we need a good history, and we need a good exam, and we may need our colleagues on board to help us figure out, why do you have low iron? And it may be that we start iron in this patient while we're trying to figure things out. That's taken on a case-by-case basis. We never start iron unless we're going to investigate the cause. So I would never give a 55-year-old woman iron pills, say, let's see if it comes up. The iron level may come up, but the issue may still be present. She still may have a bleeding ulcer, and the iron comes up, but she still has the bleeding ulcer. Or she may have another cause of excessive demand or increased loss or poor nutrition. And so we do need to investigate the cause and not just give iron. Remember that there are certain screening tests that are important for certain age groups. And the U.S. Preventative Services Task Force, U.S. PSTF, recommends colonoscopy in all patients 45 to 75 to screen for colorectal cancer. And the age is coming down. It used to be higher, now it's lower. So all patients in the U.S. are recommended to have screening. And with family histories, it's even lower. And so in a patient with a ferritin of 15, I would say to the patient, have you had routine screening? Have you had a colonoscopy? Have you had a mammogram? What other screenings are relevant in a 55-year-old patient? Those are the two most important ones. But a 55-year-old patient should have a colonoscopy. That's part of the recommended screening in many countries. And so if the patient hasn't, I would certainly recommend this be done as soon as possible. So there's nothing wrong with starting iron, but we need to figure out why the iron is low. And we never prescribe iron without determining why the ferritin is low. You need to write on the page, patient has low ferritin. I think it's because of poor nutrition. But we need to come up with a reason before you give iron. And if you don't know the reason, ask someone to help you. Mammography is also necessary. So in a patient with low iron and shedding, and just shedding in general, I want to make sure all the screening tests are up to date. A 55-year-old patient should have mammography. The US PSTF says women 55 to 74 should have screening every 2 years. So I want to make sure colonoscopies screening is done and mammography screening is done. And if there's any other screening that comes to presence, I want to make sure it's done. There's so many causes of low ferritin. Seborrheic dermatitis. I wonder here if there's a component of seborrheic dermatitis. The scalp's a little bit red. There's a bit of itching. You can get itching from Telogen effluvium. So I'm not 100% sure. Trichoscopy will help me. But I need to see the scalp up close. With a patient with possible seborrheic dermatitis, there's nothing wrong with using an anti-dandruff shampoo and a mild corticosteroid to see if the redness disappears, to see if the itch disappears, and if it's completely gone, then I might be confident that it seems to be seborrheic dermatitis. Now, of course, I really want to be confident it's seborrheic dermatitis by performing trichoscopy and convincing myself that there's yellow scale on the scalp, and there's redness, and there's some blood vessel patterns that fit the trichoscopic appearance of seborrheic dermatitis. But in a situation like this with some mild redness and itching, I might send the patient home with a dandruff shampoo, use it twice a week or once a week or 2 times a week or 3 times a week, put it on the scalp for 2 minutes or 3 minutes, We don't necessarily have to go to the 5 minutes. But we can use zinc pyrithione, we can use ketoconazole, we can use cyclopyrox, we can use selenium sulfide. And then we'll see what happens. And I might give a corticosteroid lotion, a mild one like betamethasone, a couple times a week, 5, 10, 15 drops when it's itchy. That's a very safe dose, doesn't get absorbed, doesn't thin the skin. But we have to be comfortable with the causes of a red scalp. And I do think this patient has some very mild redness in the scalp. Seborrheic dermatitis, psoriasis, scarring alopecia, autoimmune conditions, lupus, discoid lupus, dermatomyositis, allergic contact dermatitis, irritant contact dermatitis, rosacea, infections, sunburns, excessive sun exposure in one's life, excessive corticosteroids giving telangiectasias or dilated blood vessels can also give red scalps. Polycythemia or increased blood vessels packed with red blood cells. It's a rare hematologic condition, but it gives red scalps. And then the red scalp syndrome, which is a condition which is a diagnosis of exclusion to some extent, where patients have red scalps. And it's just because their scalp tends to be more sensitive and irritated to things. And it's not rosacea, it's not seborrheic dermatitis, it's not psoriasis, it's none of these other things, but it's red scalp syndrome. And so when I have a patient with a red scalp, and when you have a patient with a red scalp, you might ask yourself, am I sure of the diagnosis? If I'm 100% sure, then treat it. If you're 100% sure of the reason for the red scalp, I think it's psoriasis, then go ahead and treat it however you treat psoriasis. If you know it's seborrheic dermatitis, go ahead and treat it. If you're really not sure, I have no clue. Consider a biopsy or refer to someone who can help you. If you have a red scalp and you're somewhat sure, I think I know what this is, then you might want to consider short-term treatment. See if it responds the way you would expect that diagnosis to respond. If a patient has really mild seborrheic dermatitis, I think this is mild seborrheic dermatitis. I think this patient is itchy from some really mild seborrheic dermatitis. I'm going to give some dandruff shampoo, some mild steroid, and we'll see the patient back in 3 or 4 months. We'll see if the redness and itching goes away. And if it does, then I'm still pretty sure. Or maybe I'm 100% sure now. I think this is responding like I thought this would. But if you're not sure, or the patient comes back and it's way more red, these dandruff shampoos didn't work, or the corticosteroid didn't work, then you have to biopsy or refer. We need to move forward with being sure of diagnoses. We don't have to be sure on day 1, but you need to be sure at some point within the first few months. Because if you're dealing with a scarring alopecia, we don't want too many months to go by because there may be permanent hair loss. So let's summarize. This is our first module of CHIRPS, and if you've joined us this far, I want to thank you. I hope this has been helpful. We've talked about the hair loss timeline, and this patient has a hair loss timeline shedding pattern that looks somewhat like this. There's features of a telogen effluvium, 2 back-to-back telogen effluviums, perhaps with different triggers. The shedding has been ongoing. It started postmenopausally, and we need to be sure there's not a component of androgenetic hair loss here. I want to be sure by trichoscopy, or a biopsy, or a 5-day hair collection, or a clinical examination showing there's less hair here than in the back. But we need to make sure we answer the question, does this patient have androgenetic hair loss? And so the patient has submitted these photos, which shows a widened part, very slightly widened part. This would be a Sinclair grade 1.2 or 1.3, whereas Sinclair grade 1 is normal, and then it goes 2, 3, 4, 5. And so if we're thinking androgenetic hair loss, this would be a less than a 1.5. But if we find that this isn't truly androgenetic hair loss, then we wouldn't use the term Sinclair's grading in this situation. That only applies to androgenetic hair loss. There's hair loss in the temples here. We have to be careful. That certainly is in keeping with telogen effluvium, but androgenetic hair loss can also have changes in the temples. I do think there's a bit of redness here. I do think there's some redness in the front of the scalp. I don't see any features of frontal fibrosing alopecia. But this may be in keeping here with some seborrheic dermatitis. The skin is a bit red and a bit flushed. There is hair growth here. There is hair growth here of about 6 centimeters or so. So there does appear to be some regrowth happening. And so I do think the second episode of telogen effluvium is settling. But is it going to settle fully? And is the patient going to get the density back? And is there something else here besides just a second episode of acute telogen effluvium? Is this chronic telogen effluvium? Is this androgenetic hair loss? And I do think there's some hair loss in the front, slightly more than other areas, perhaps in a triangular shape, suggestive of the Olsen pattern, but I really need to see the scalp up close, and trichoscopy will help. And I do think there's some redness in the scalp at the forehead. The back of the scalp is widened. And so I do think there is a component of true diffuse hair loss here, which is suggestive of telogen effluvium. It's a little bit too early in the course to really convince myself this is diffuse androgenetic hair loss, which some women have. That usually happens a bit later. And so how do we treat it? Well, remember, we treat hair loss by treating all the causes. And so the first step is to figure out all the causes. We go into the room with 20 diagnoses on our page and we cross them out. We leave the room with 2, 3, 4, or 1 diagnosis. So if there's telogen effluvium, we have to treat all the causes. So if there's telogen effluvium from low iron, we have to treat the low iron. If there's a telogen effluvium because of low iron plus stress, we really want to help the patient with stress. If there's a telogen effluvium due to low iron and stress, and possibly some other autoimmune issue, we want to address that as well. If the patient is sensitive to medication changes, we want to encourage the patient to maintain the dose if at all possible. It's okay to start iron, but we want to investigate the cause of the low iron to make sure we understand why. If it's androgenetic hair loss, we can begin treatment with any of the evidence-based treatments for androgenetic hair loss, including topical minoxidil, finasteride, oral minoxidil, laser, PRP, or a hair transplant. Now, I might not be keen to suggest hair transplant in this case because of the shedding component that's here, and it is relatively early, and we haven't figured everything out. So hair transplant is probably not the option we should be considering or discussing. But these options are all quite good. Topical minoxidil may be a reasonable plan if we can get the telogen effluvium under control. What I'm worried about if a patient is still shedding is if we start topical minoxidil, oral minoxidil, that we may just perpetuate shedding, and it may just be massively increased shedding and very troublesome to the patient. So in a situation like this with early shedding, I may say to the patient, let's get the shedding under control. Let's get the shedding stopped with anti-dandruff shampoos, topical corticosteroid, getting your iron levels up. Let's see where we're at in 4 or 5 months, and then maybe we'll address the androgenetic hair loss if we think there is androgenetic hair loss. That's a great time to start topical minoxidil or oral minoxidil or finasteride or laser or PRP. In a situation like this, my preference probably would be topical minoxidil or oral minoxidil, followed by finasteride and laser. And in a case like this, perhaps it would be topical minoxidil compounded with a topical anti-androgen like finasteride if the patient didn't have any contraindications. If she's having menopausal symptoms, hot flashes, we have to be aware that finasteride sometimes does worsen hot flashes in some patients. And all these treatments can worsen shedding when we start. If there's a component of chronic telogen effluvium here, oral minoxidil would rise to the top of the list as one of the more effective treatments, followed perhaps by laser. We can do 2 treatments together. The problem is if we start 2 treatments together, or 3 treatments, or 4, we have no idea which one is working if the patient improves. That's my view on treatments. That's certainly not the view of everyone. Some people throw the kitchen sink at the condition. I really like to know what's helping, and I really like to know what's not helping. I don't want my patient to use a treatment for their life if it really is doing nothing. So I prefer to start 1 or 2 treatments at a time, wait a few months, see what's happening, add the second, add the third, but to have time in between. So this comes to the end of Module 1. We've reviewed the causes of telogen effluvium, the SEND mnemonic: stress, scalp diseases, endocrine diseases, nutritional issues, low iron, and drugs and medications, and systemic diseases. We reviewed the importance of low iron levels in postmenopausal women. Most postmenopausal women have ferritin levels in the 50s, 60s, and 70s, and they rise with age. And so if you're dealing with low ferritin levels in postmenopausal women, it really needs to be taken seriously. We reviewed the 4 categories of conditions that cause low iron, and that's really important to remember as you're asking your patient question. Is it from poor intake into the body or poor absorption? Or is it from increased loss? Or is it because the body's using it up quickly? We reviewed the differential diagnosis of a red scalp, so it's really important to be aware that seborrheic dermatitis and psoriasis are really common causes of a red scalp, but you need to be aware of those other causes and be comfortable with them and learn about them over time. What is scarring alopecia? What is allergic contact dermatitis? How does it present? What is irritant contact dermatitis? What is scalp rosacea? What is dermatomyositis? What is the red scalp syndrome? So there are many causes of the red scalp. And we reviewed the differential diagnosis of chronic shedding, and we reviewed the fact that it's so important not to equate shedding with telogen effluvium. Shedding happens in androgenetic hair loss. Acute telogen effluvium, chronic telogen effluvium, scarring alopecia, seborrheic dermatitis, psoriasis, alopecia areata. So remember that shedding does not equate with telogen effluvium alone. And that brings us to the end of this module. And if you're participating in this module as part of the Donovan Hair Academy, then we will certainly be talking about these modules as part of our courses that you will be completing. If you're completing these on your own, then I hope that this was helpful, and I hope that you have found this to be informative, and I hope that it has fine-tuned your skills in diagnostic reasoning and problem solving, as that is actually the goal of the CHIRPS program. I will leave you now and say goodbye until we meet again for another module of CHIRPS. I will leave you with some multiple choice questions that you can think about and reflect on your own as you complete this module. I thank you again. Bye for now.